This Week in Virology, the podcast about viruses, the kind that make you sick.
From Microbe TV, this is TWiV, This Week in Virology, episode 870, recorded on February 24th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Washington, D.C., Daniel Griffin.
Hello, everyone.
How is the COVID situation in Washington? Any different from New York?
I haven't looked at the numbers too much, but I've been watching behavior, because we're actually going and trying to do some things. We're staying mostly outdoors. It's actually been easy to eat out a lot on sort of the outdoor, the alfresco type dining. People seem to be behaving themselves. We were just in the Congressional Library of Congress today. Everyone wearing masks, people distancing, not a lot of crowds. So far, I feel like it's a safe, comfortable experience.
Very good. Sounds great.
All right. Well, let's get going. This I have to say, this has been a tough week, Vincent. The first, I'll start with our quotation, and I think people will understand why this has been tough. If I am hungry, that is a material problem. If someone else is hungry, that is a spiritual problem. And that's Paul Farmer. And as people may have heard this week, Paul Edward Farmer died. And he died a young man in his early 60s. So this is tough. This is a tremendous loss. People not familiar with Paul Farmer might want to read the book Mountains Beyond Mountains by Tracy Kidder, really getting a glimpse into just a tremendous human being, just really a horrible loss. And unfortunately, Paul, very much to his tradition, was down in Rwanda, up in the mountains, taking care of people, and unfortunately died in his sleep from a cardiac event. So really quite a loss. The other thing listeners might have known or not, I was supposed to be in Kiev, Ukraine at the moment. My wife's sister is married to a diplomat, so she and my brother-in-law were in Kyiv. We were going to visit them, but as we know, there's all those political issues going on. So a tough week, but we still have tough issues COVID related. So let me start with the update with the mention of the Omicron subvariants again. And I'll focus a little bit on BA2, or what is referred to as the stealth variant. It does appear to have some degree of a fitness advantage because we are seeing an increase in prevalence. But I still think it's very premature to be saying much about the mechanism of this fitness advantage, severity of disease. But this really does continue to be a problem, mostly for the unvaccinated. Don't worry. There are already some experts claiming to know why it has a fitness advantage already, to tell you that it's more virulent. I'm going to be old-fashioned and actually wait till I have science to help on those issues. But as I learn more, we'll make sure that in each section, I'll reference what we know. But when we get to our section on monoclonal antibodies, I will discuss the potential impact on Evusheld, on Sotrovimab, as the prevalence in some areas. We break down the U.S. into these different regions. In the New York, so that's region 2, we're still down about a 4 or 5%. But region 1, right, that's just north of us: Connecticut, Massachusetts, Rhode Island, Maine, New Hampshire, Vermont. They're up to about 7%. So the FDA has already repeated their warning about, you can't use monoclonals when they cease to be effective. So we're going to have to keep our eye on BA2. What about case numbers? They are dropping. I just want to keep people connected to what's going on with Omicron in terms of numbers. February 23rd, what about deaths? 2,440 deaths recorded here in the U.S., over 10,000 deaths worldwide. In New York on the 22nd, we had 158 deaths in a single day. I do wonder if there's any amount of data that will get people to stop using the word mild in reference to Omicron. Once it got in there, it just continues to echo. But I do want to point out the height of deaths during Omicron and the time above 2,000 deaths per day. With Omicron, we've been above 2,000 for twice as long. Just a reminder, COVID-19 is killing more people now than during most of the pandemic. And yes, this is Omicron. So I think that will influence when I talk about some other topics going forward, particularly when we get into children. But I'm going to expand this section a little bit. I would say children, COVID, mental health. I'm also going to say and other vulnerable populations, because I think it's important to expand this section as we go forward, just realizing that we still have large segments of our population at risk, unable to enjoy the full benefits of vaccination protection. It's estimated that we have over 20 million children under 5 in the US. We have over 50 million individuals over the age of 65, many of them with comorbidities, a large number of our population with medical conditions that put them at higher risk of a bad outcome. It's also estimated that about 3% of the US population, or about 10 million people, are immunocompromised. The CDC actually has a page devoted to individuals with higher risk medical conditions in the context of COVID. But I just wanted to sort of put this in context, maybe address some of the myths. There's an article published in 2016 that is not so old that we can disregard it, and it was Prevalence of Immunosuppression Among U.S. Adults, 2013. This was published in JAMA, and there's a really nice figure in this paper. One of the things I like about this is that it breaks down the immunosuppressed into different age groups. I think there's this perception that somehow we know who are immunosuppressed, that this is really pretty much the older folks. But what we can see if we look at that figure, and I do recommend people take the time to look at this. It does not appear to be behind a paywall. But if you look at those youngest individuals that they looked at, 18 to 39, between 1% to 2%, it's actually about 1.6%, or about 1 in 60 people in that younger age group are immunosuppressed. If we look at females, the number goes up. Certain ethnic groups, it goes up even a little higher. So think about this when we're kind of moving forward. You're in a movie theater with 100 people. Perhaps you're in a lecture hall with 100 students. On average, 1 to 2 out of the 100 will be immunosuppressed. Ed Young recently wrote a nice piece for The Atlantic, "The Millions of People Stuck in Pandemic Limbo. What does society owe immunosuppressed people?" It's a really nice article, and I recommend people look at this, because as we go forward, this is going to be an issue. All right, focusing.
And Daniel, I guess
Yes.
this is a whole range of immunosuppression, all different B cells, T cells, everything, and so innate immunity and so forth. Is that correct?
I think it's good that you bring that up, Vincent. I'm glad you did, because, and I want to bring this up in a reassuring. The person who has lupus and is on a low dose of an immunosuppressant, that's not the same as someone with a kidney transplant. So when we hear from the CDC, Dr. Walensky was talking about, who it is that are still dying despite vaccination. She really made the point, and it's tough because, it's political. But the people that are dying despite vaccination, despite our therapeutics, they tend to be almost all of them. So 75%, over 75, 4 or more medical conditions. So every degree of immunosuppression is not the same. So, if you have an immunosuppressed condition, don't feel like you're being left out in the cold. Talk to your physician. Your level of immunosuppression might be different than someone else's. And also, as we'll get, there are things we can do. And in coming weeks, we're going to have better access to therapeutics. So I think that's important. Immunosuppression is not a binary.
Also, Daniel, there are people immunosuppressed because of, say, transplants or HIV/AIDS, but then they're also with genetically based immunosuppression, gamma globulinemia, SCID, so forth, right? So who's in the majority? Do we know?
It's interesting. It's evolving over time, right? We're doing more organ transplant. That population
Yeah.
is growing, but no, that's not the main population. It's a lot of individuals. Actually, a lot of individuals are, as mentioned, medically immunosuppressed. They're on therapeutics that are interfering with their responses. But yeah, as we get better at medicine, better at keeping people alive, the comment an individual made to me in Ghana, Dan, the people with comorbidities, they're not still alive, right? I mean, we're doing a really good job of giving
Yeah.
these people, extra years. So, all right, no, but excellent. Thanks for bringing that up, because I think that this is not binary. This is a complex population. I like to say people living with immunosuppression, not defined necessarily by it.
Mm.
Back to children. How are we doing there? Vince, you got to make Dixon listen to my episodes too, because he seemed shocked when I mentioned that children were dying from COVID-19. And what I will
Daniel,
say,
he doesn't even listen to our episodes.
he doesn't even listen to you when he's on the show. Okay. All right. Don't have Dixon listen to this. They'll say we're not being nice to him. All right. Dixon, if you're listening. Anyway, so what about pediatric deaths? We are still another 20 pediatric deaths for the week ending 2/17, right? So for the last 3 weeks that we have data, we're still averaging about 3 pediatric deaths a day. This is terrible. What about hospitalizations? It was a nice MMWR. Hospitalizations of children and adolescents with laboratory confirmed COVID-19. And I'll just go ahead and say in this data, so coinciding with increased circulation of the Omicron variant, COVID-19 associated hospitalization rates among children and adolescents ages 0 to 17 years increased rapidly in late December 2021, especially among children aged 0 to 4 who are not yet eligible for vaccination. Now, the Omicron variant peak was 4 times that of the Delta variant peak in terms of hospitalization for children. 1,000 children a day getting hospitalized. So, I think that this is one of those. These are the numbers. These children still, we're hearing that we're not going to have vaccines until maybe April at the earliest. So, when we're moving forward, we still have this high risk population. And yes, children die of COVID. I was over at the Lincoln House. This is actually where Lincoln spent some time. And I was in the room today where he wrote the Emancipation Proclamation. And the person was talking about, very distracting for Lincoln. They were burying, 40 Union soldiers a week. I'm like, you know what? We're burying 20 children a week from COVID. So just to give this context. Transmission testing. I think we're doing better with testing. So let's continue with that. This is not the time to stop. If you're feeling crummy, decide to skip that test and head to a Super Bowl party. Pre-exposure period, NPIs. We're actually expecting guidance on masks from the CDC. We're expecting some changes. Currently, we're slated next month to have masking end on airplanes and other situations like that. So, as I mentioned, this is why I bring up the immunosuppressed, because for many of us, we've got the protection of those vaccines. But for many in our society, this is going to be tough in the coming weeks. Active vaccination, never miss an opportunity to vaccinate. There's a lot happening here. A few changes in the CDC recommendations on COVID vaccination, and they updated this webpage on February 22nd. And that was Tuesday, right? So it was 2/22/22. We should have recorded this at 2:22 in the afternoon, but they added a consideration for an 8-week interval between the first and second doses of a primary mRNA vaccine schedule. So we've talked a bit about the logic before, and the fact that this was perhaps less than ideal from an immunization, from an immunology standpoint. The idea that, okay, we're in a pandemic, we want to leave these people unprotected for as short a period of time as possible, getting that second dose in. But the thought over time that if you wait for about 8 weeks before you get that second dose, maybe we're going to get a robust response. Also, and I think this is important as well, there's a suggestion that this may even decrease the incidence of myocarditis. So there's actually a little bit of a qualification on the CDC recommendation saying an 8-week interval may be optimal for people aged 12 years and older, especially for males aged 12 to 39 years. So a little bit more flexibility. But what I want to say here is active vaccination recommendations have gotten rather complicated. So for a lot of us taking care of particularly immunocompromised individuals, we're going to have to start looking at these tables. As mentioned last time, for the immunocompromised, there's actually 3 doses up front for the mRNA vaccines, right? So first dose, 3 weeks later, second dose, 3 weeks later, third dose, and then 3 months later is that fourth, or shall I say, boost. So getting a little complicated. So we'll have to keep looking this stuff up, making sure we're staying up to speed. Even the CDC, I have to say, I've gone through their different pages and not all of them are updated. But another vaccine option might be coming our way. We recently heard that Sanofi and GSK will seek regulatory authorization for their recombinant protein-based vaccine. So this is a 10 microgram antigen formulation of the SARS-CoV-2 adjuvanted recombinant protein-based vaccine to be given as a 2-dose primary and then probably followed by a boost. Similar tried and true tested technology as Novavax or the Shingrix shingles vaccine. We have a press release at this point with some data. And so what do we know? So the final analysis of the global VAT02 booster trial confirms universal ability to boost neutralizing antibodies. So that's the boost role. But we also have a VAT08 phase 3 primary series trial. 2 doses of the Sanofi GSK vaccine in seronegative populations. What did we get? 100% efficacy against severe COVID-19 disease and hospitalizations, 75% efficacy against moderate or severe COVID-19, 57.9% efficacy against any symptomatic COVID-19 disease. So just a couple things to throw in here. Really encouraging data for a primary 2-dose series. But as I also mentioned, we have that other trial showing that we can use this as a boost, increasing those neutralizing antibodies 18 to 30-fold. And if we boost after a primary series with the Sanofi GSK, with the Sanofi GSK as a boost, they were reporting neutralizing antibodies increased 84 to 153-fold compared to pre-boost levels.
Daniel, what was the gap between the 2 doses?
I believe it was 3 to 4 weeks, but I do not have it mentioned here. So yeah, again, sort of that front-loaded short interval.
Yeah. And what would be the reason for boosting with this as opposed to mRNA or adenovector, for example?
Yeah, I mean, so we just recently ran into the issue with healthcare workers requiring that they be boosted, and a number of individuals, right? They tolerated the first dose, then they had an issue with that second dose, and so boy, this is another option. Some of the second doses, clear cut, PEG, something like that. Some of the other, let's say you had myocarditis, something like that. This might be an option for saying, I want to sort of jump ship, try a different platform. What about the science behind vaccination versus just getting infected? Sort of an interesting meme I was reading lately about people who want to get infected to protect them against getting infected. It was sort of funny, the whole point that, well, then you're getting infected and all the risks that come with getting infected. Well, the preprint SARS-CoV-2 Omicron triggers cross-reactive neutralization and FC effector functions in previously vaccinated but not unvaccinated individuals. So this is up as a preprint. And the researchers used plasma from 20 unvaccinated and 7 vaccinated individuals who were then infected during the Omicron wave in South Africa. They went ahead, they tested binding, antibody-dependent cellular cytotoxicity, antibody-dependent cellular phagocytosis, right? So neutralization against VOCs. In unvaccinated individuals, they found that Omicron-triggered neutralization was not extensively cross-reactive to other VOCs, variants of concern, with 20 to 43-fold reductions in titer. In contrast, and this is really the important, vaccination followed by Omicron infection improved cross-neutralization of variants of concern with titers exceeding 1 to 2,900. So a couple interpretations by the authors. This has important implications for the vulnerability of unvaccinated Omicron-infected individuals to reinfection by circulating and emerging variants of concern. Further, while Omicron-based immunogens may be adequate boosters, they are unlikely to be superior to existing vaccines for priming SARS-CoV-2 naive individuals. Well, interesting speculation in the last sentence. I'm not sure. I mean, the science will tell us. But interesting, sort of building this story that people who get infected by one variant seem to have some degree of protection against the same variant, but really showing that vaccination prior to infection really triggers a better immune response. Now, this next paper is one that Amy sent my way. SARS-CoV-2 reinfection prevents acute respiratory disease in Syrian hamsters, but not replication in the upper respiratory tract. So this is available currently as a journal preproof, accepted for publication in Cell Reports. I really like the introduction, actually, and I encourage our listeners to read this. The authors point out that reinfection with coronavirus is not unprecedented and has been clearly demonstrated for 3 of the 4 seasonal human coronaviruses, so NL63, OC43, and 229E, prior to this current COVID-19 pandemic. They point out that before the COVID-19 pandemic, we already had evidence that immunity gained from primary infection with these seasonal coronaviruses can wane quickly. And they reference a number of studies, including one study demonstrating reinfection within 6 months of primary infection at a rate of, respectively, 21%, 5.7%, and 4.0% for NL63, OC43, and 229E, respectively. They also describe that some of the first patients in this paper who had that documented reinfection. I still remember the days when there was really, I think a lot of people did not want to believe that you could get reinfected. It's now clear that reinfection is not uncommon. And we now have several examples of people that have had worse outcomes with a second infection compared to their first, including hospital admissions, ICU admissions, and death with a reinfection after surviving the first infection. In this study, the investigators looked at homologous reinfection, so getting reinfected with the same isolate, and heterologous reinfection, so getting infected a second time with a different isolate. The good and the bad, it did appear that prior infection conferred protection against severe disease in the hamsters for a period of time that they investigated, but it still looked like there could be robust replication in the upper tract with those reinfected, potentially allowing them to participate in onward transmission. That's the bad. Lots of limitations, as the authors acknowledge. But this is an important topic to investigate, as I know a lot of people are, looking at this situation. A lot of people have been infected, then been vaccinated, or been vaccinated and then been infected. Still a lot of people that have been infected, not yet been vaccinated. So just more science are helping us sort that out. I also think it's important as numbers are decreasing and we as a country appear to be moving away from non-pharmaceutical interventions such as masks, distancing behavior, that we look at the fact that only 65% of Americans are fully vaccinated. It's a little more encouraging in that the percentage fully vaccinated is highest in the highest risk group, so the over 65, but then starts to drop in the 18 to 64. And by the time we get to the 5 to 11, we're down to only about 25%. It is regional, but I know a lot of people are hoping that prior infection are going to help us here. But we're seeing a falling off of people showing up for those first vaccine doses. We've tried carrots, we've tried sticks. Perhaps we could try a little more science communication. I wanted to actually, again, keep hammering on the same topic, the concept of reinfection. And I'm actually going to bring up a paper that was published a year ago direct observation of repeated infections with endemic coronavirus, published by Marta Galanti and Jeffrey Shaman, who's been on TWiV. They presented data from proactive sampling carried out in New York City, and they noticed no significant differences between the probability of testing positive at least once and the probability of a recurrence for the beta coronaviruses HKU1 and OK43 at 34 weeks after enrollment first infection. They also found no significant association between repeat infections and symptom severity. It's just this big thing. I think whenever I bring up, oh, we're here with the vaccines, people are like, oh, but can I just add, prior infection on? Aren't those people going to be just okay? And I think this is the big challenge with all these discussions of herd immunity with prior infection, is that coronaviruses, this is sort of their operandus modi, is they're associated with reinfections, and that reinfection, as we have a recent celebrity person, second infections can be really bad and actually worse than the first. So.
Well, Daniel, there was no reason to think in the beginning that we wouldn't get. I remember that, though, very early on, people thought, oh, we're not going to get reinfected. But that not only ignores what we know about common cold coronaviruses, but most other vaccines against viruses which don't prevent infection, right? So I'm not clear why we got into this mode. You and I did not, but why did the mass media get into this mode? There are certain pundits who told them this.
Yeah, I think that's what it is. I think people wanted, it's reassuring. People wanted to hear one and done. And, and then when it turned out it wasn't true, they still didn't want it to be true. And passive vaccination, Evusheld, we're still using that. So just continue to think about that. As we mentioned, if you have an individual who cannot develop that robust protective response to vaccine, this is something that is available. At this point, it's every 6 months. We'll see how that goes. Hard to predict that far out into the future, but number of patients we've been using this in, very well tolerated. So want everyone to remember that as an option. All right, the period of detectable viral replication. So everything has fallen through. The person is now tested positive. I like to say this is the time for monitoring monoclonals, antivirals, and enrollment in clinical trials. Not the time for steroids or antibiotics or zinc or aspirin or other unproven and potentially harmful potions. I'm going to emphasize antimicrobial resistance here. And I want people to go. I'm going to plug one of our other shows, TWIM 259. This is where there's really a great discussion. Actually, I have a paper I was going to discuss, so I will only briefly mention it here, but just published in The Lancet, Global Burden of Bacterial Antimicrobial Resistance in 2019, a systematic analysis. Now, as we've discussed several times, despite really good data that there is no benefit to antibiotics to treat a virus during the first week, there's really no benefit to treating viruses with antibacterial agents, which is what is happening here. And even that doxycycline study we discussed, where there was higher mortality in the antibiotic treated group, the majority of people with COVID-19 are still getting antibiotics. Ouch. Well, what that is doing is that is feeding antimicrobial resistance. And the authors in this paper estimated that over 1 million deaths were attributable to antimicrobial resistant organisms. These were mainly lower respiratory infections, bloodstream infections, some intra-abdominal infections, urinary tract infections. E. coli came out as number one, followed by Staph aureus. I think what triggered me, Vincent, I will say I made the mistake of looking at one of the comment sections on one of the TWiVs. I think it was the last time where I talked about how azithromycin was not helpful. And then someone's comment was, but I'm over 65. I might just take a Z-Pack to be safe. It's not safe. It's ineffective. It's potentially harmful. And you know what? You might not die in the next few weeks. So you are going to join us going forward into the time when our antibiotics stop working. And who is the most at risk for an antimicrobial resistant organism? The person who has recently taken antibiotics and selected that. So, this is not helpful. It is harmful. Those of us that took some kind of an oath, keep in mind, do not contribute to this. Please be good stewards of antibiotics. Okay. Ivermectin. Vincent, I'm going to talk about ivermectin, but which study shall I talk about? Well, this was ivermectin does not protect against SARS-CoV-2 infection in the Syrian hamster model. These investigators found that ivermectin did not reduce lung viral load and even significantly worsened the SARS-CoV-2 induced lung pathology. They even looked at combining with molnupiravir, and you know what? That wasn't helpful either. So just I want to keep pointing out here, if you're excited about ivermectin, look at enrolling in a clinical trial. We do not have any reliable studies that were done, that were not plagiarized, that were not fraudulent, that really are compelling for the use of ivermectin at this point. So I know I'll get some
Danny,
nice...
we do have some ongoing trials currently now, right?
Yeah, we have two really big trials. There was one that was recently published that was not supportive. They're still waiting for the COVID out trial, fully enrolled. So we're really waiting to see the data from that. And we still have the Active 6. So we're gonna get more data soon. But you know what? We're 2 years into this, and I have yet to see any compelling placebo, randomized control, properly done studies that show ivermectin work. There's a lot of stuff out there that now we realize trials that were never done, people who fudge the data for whatever agenda. So ivermectin at this point does not have a role in the treatment of COVID-19. And you can quote me on that. Okay. All right. But what does have a role? Because we do have options here. Paxlovid. We are headed towards better access to the highly effective outpatient therapeutics for acute COVID-19. And we have a couple things working for us here. One is the number of acute cases is dropping, right? So the demand is going down. So far, more than 500,000 courses of Paxlovid had been distributed to the states. This means that we're having better access. It's still not great across the whole country. We're not quite there. We're almost there. I expect next month to be when we really are at that point where when we want to get Paxlovid, we can. I'm also hoping it's at that point where it's just a matter of clicking it on your electronic medical record. A lot of us do e-prescribing on our phones. At this point, it's still picking up the phone. It's still knowing where to call, talking with the pharmacist, knowing one, is my patient high risk and is this warranted? 2, what's the kidney function? 3, are they on any other medications? Funny enough, last time I was with my parents, I ran through their kidney function, their medicines, just making sure we were good to go should they get an infection. And to give people follow-up, our 75-year-old with CLL, we talked about last time, got started on Paxlovid that same day, and so far, so good. All right. If Paxlovid, right, 88 to 89% reduction in progression is not available or cannot be used, then we move to monoclonal therapy. So here's our bit about keeping track of variants. More investigations have questioned the efficacy of various monoclonals, such as sotrivimab and Evusheld, should you have the BA2 variant circulating. So the article SARS-CoV-2 Omicron BA2 variant evades neutralization by therapeutic monoclonal antibodies was posted as a preprint. This is out of Nathaniel Landau's lab over at NYU. So we now have concerns raised by investigators at Columbia, David Ho's lab, NYU. Now, these investigators used the same pseudotyped lentiviral assay and in their hands found that the BA2 evaded neutralization by all the currently available monoclonals, including sotrivimab and Evusheld. So we're going to need to keep track of that. That's the one thing about BA2 that we are starting to have some well-based concerns. Still, on the sotrivimab, GSK and Vir have submitted EUA application to the FDA for intramuscular administration. Think about it now. You've got to go somewhere. They've got to establish and maintain an IV. But here, phase 3 randomized open label non-inferiority COMET tail trial, demonstrating that 500 milligrams IM administration of sotrivimab was non-inferior and offered similar efficacy to 500 milligram IV administration. There was a 250 milligram, 500 milligram arm. The 500 milligram dosing is what they're going. But this would really be a great addition, right? Paxlovid as your first choice, sotrivimab IM, a lot easier to get into patients than having to deal with IV. All right, moving next. So Paxlovid, monoclonal, the next remdesivir. Remember, 3-day outpatient IV therapy, 85% reduction in progression if given early. Don't leave our patients without an option because the next is molnupiravir. Almost 2 million courses of molnupiravir have been distributed to the states. As I mentioned, we're not quite there yet as far as having as much as we need, but this is that last option in our acute therapeutics with about a 30% reduction in progression, hospitalizations, and death. But remember, do not wait to see how the patient does. This is a numbers game. If your patient is high risk, go ahead. If you wait till they start feeling bad, till they start getting hypoxic, you have missed your window. So unfortunately, that appears to be a continued issue. If you miss your window, you end up in that early inflammatory phase where our therapies are rather limited. Remember, steroids, anticoagulation if they end up in the hospital, pulmonary support, moving to the tail phase. And again, I feel like I'm going to keep plugging other This Week In podcasts. I really enjoyed TWiV 869, Epstein-Barr virus and MS, a perfect storm. And as we discussed on a prior episode, one of the predictors of long COVID was EBV reactivation in the acute period. We still have millions of people suffering from long COVID and other post-acute sequelae of infectious diseases. Properly funded and conducted research is how we will end up with ways to help these people. Millions of people are continuing to suffer without a lot of great options.
Daniel, it will be interesting if one of the antibodies against EBV, like in MS, it's against a nerve protein, maybe a different protein that leads to cross-reactive antibodies in long COVID, right? That could be looked at very, very easily.
Yeah, I know they're actually looking at that up at Yale, which is interesting, and a number of other labs. That's one of the ideas, right? You've triggered, and it probably is a number of mechanisms, but one of the mechanisms very well may be an antibody with an off-target impact like that. So
yeah. Yep.
So, but we need the research to sort this out, and millions of people are waiting for those answers. No one is safe until everyone is safe. I wish I had more good news here. I wish I could say, oh, we're vaccinating the world at a rapid pace, but we're not. We still have a lot of work to do. So I will remind everyone to please go to Parasites Without Borders, click donate. During the months of February, March, and April, donations made to Parasites Without Borders will be matched and doubled up to a potential donation of $40,000 to the American Society of Tropical Medicine and Hygiene, including scholarships for their annual meeting travel awards to attend the 2022 meeting in Seattle, Washington. Priority for the scholarships will be placed on females from low-income countries who might not otherwise be able to attend.
All right, it's time for some questions. Your questions for Daniel. You can send them to daniel@microbe.tv. Philip writes, I currently take atorvastatin, which I understand is not compatible with Paxlovid. I would think about suspending it if I got COVID and say to hell with the lipids for a week or two. I have an appointment with my doctor in April. I may discuss switching to another statin. What are your thoughts on this to TWiV land?
Yeah, so this is perfect. Vincent, this may sound like an esoteric question to you, but this is my bread and butter. So I've been actually going through, because what they say now is, it's binary. If they're on this, you don't want to use the Paxlovid. Look at those medicines. Start using medicines that don't have cytochrome P450 interactions, because COVID is here to stay. And at this point, Paxlovid is the most effective therapy. So it's a very simple to say, you know what? Let's switch from that Lipitor, that atorvastatin, to Crestor. That's one of the alternatives that doesn't have interactions. And then you're good to go, because that's what you want to do. You want to be good to go. You want to have a plan, because COVID is here to stay.
Madeline writes, COVID has finally found my family. And of course, the experience brings up some questions. My husband and I are both 32 and triple vaxxed. We have a 7-month-old son who obviously is not. Due to a negative rapid test about 24 hours post-symptom onset, we thought it wasn't COVID. And by the time we had a rapid come positive the next day, my son and I were clearly improving. This was really the best case scenario without having the stress of worrying about COVID while it was in the acute phase. I now know that my son has some active immunity and didn't have to suffer much for it. But then I was thinking about how hospitalizations aren't really due to the acute infection so much as the inflammatory phase of the disease. And I wondered, are we necessarily in the clear yet? For example, if classic COVID is a weak viral and a weak inflammatory, would you expect that a 2-day viral course would also have a 2-day inflammatory phase? Or does SARS-CoV-2 only get the immune system really revved up when it's a lot of virus? Or is it a lot of virus for a long time that matters? For us, it feels like it will be another day or two of feeling crummy. So I'm not worried, just curious.
Yeah, no, this is great. Particularly in people who are vaccinated, I'll say quite often in younger, healthy individuals, that initial viral phase can actually be pretty mild. A chunk of people have asymptomatic. We're starting to realize not as many people, if we really watch closely, are asymptomatic. There was actually a nice recent study in healthcare workers where they observed them and realized that, yeah, actually completely asymptomatic is not as common as people once thought. But a lot of people never even have a noticeable early inflammatory phase. They feel crummy for a few days, and then that's it. It's the people who feel crummy, maybe start to feel better. And then I remember, Ian, first I had a virus, but then I got COVID. Yeah, that's the experience that some people get. They feel like they have a virus, and then boom, they feel like that early inflammatory phase. So hopefully you will not even experience the early inflammatory phase. So fingers crossed.
Fiona writes, hi, Daniel, or rather, Kia ora, as I'm writing from New Zealand, and Te Reo Maori is an official language here. Here in New Zealand, Aotearoa, our vaccination rates for adults are getting good and high. Third dose rates are climbing too. However, children between 5 and 12 are still only on their first dose of the vaccine, as New Zealand is doing an 8-week gap between doses. Good for them. We're just going into our worst wave of COVID. We were able to pretty much hold off SARS-CoV-2 until very recently and get vaccination rates up as much as possible before Omicron started spreading. How will our children fare against Omicron with just a partial dose? It's possible second doses will open up sooner than 8 weeks. But if not, our 11-year-old is 2 weeks away from being eligible for his second vax. Then there'd be a bit of time needed for that to work effectively, I think. So that's potentially a month without good protection against Omicron. What would your recommendations be?
Yeah, this is a very timely email. I only sent you my notes about 15 minutes ago, Vincent, so I know you didn't have time to plug this, but this is great. Why did we do 3 to 4 weeks? Why are we now talking about 8 weeks in younger individuals? From an immunological standpoint, waiting the 8 weeks seems to give better response, more robust response. The 3 to 4 weeks was a height of pandemic response. Also, we're seeing some evidence, a recent study out of Canada, that you're really going to be reducing those myocarditis risks by waiting 8 weeks instead of doing it right in the first 3 to 4. So I actually think this is a reasonable approach. I'm going to just encourage you, be careful, continue to protect your children during these several weeks. But remember, this is a marathon. SARS-CoV-2, the virus, it's here to stay. It's in animals. We're always going to have the unvaccinated. We're always going to have people coming from unvaccinated populations. So I actually think the science really supports this strategy. And just like Vincent, kudos to this approach.
And Fiona writes, thank you, Na Mihi. And finally, Mary writes, given the CDC report from 122 showing decreased COVID vaccine effectiveness for EDUC visits and hospitalizations 4 months post-booster, would it be advisable for a pregnant woman whose delivery date is 4 months past her booster to get another shot? So a fourth shot, would age be a factor in this decision?
Yeah, so we talked a little bit about this last time. So, being pregnant is a dangerous time to get COVID, both for the pregnant woman and for the unborn child, right? Increased hospitalization rates for the pregnant woman, increased loss of the child during pregnancy. But we also talked about how the being vaccinated during pregnancy can potentially transfer protection to the unborn child. So we're still waiting for a little bit of details here. Does it make sense to get that booster in that last trimester, let's say 3 or 4 weeks before the scheduled birth, to sort of augment that? The science is building to support that kind of a scenario.
That's COVID-19 clinical update number 103 with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you, Vincent. And thank you, everyone. And remember, be safe out there.